He discussed few important diseases of our societies: diabetes, hypertension, smoking, and many others. One of the most alarming conditions in our country has been viral hepatitis. Hepatitis B being a very prevalent condition here. Its treatment from time to time, indication for treatment, it has changed. But we have got the new advances in the treatment of hepatitis B. For a talk on this topic, we have got a very experienced professor of general medicine and gastroenterology, Professor Dr. Javed Iqbal FAROOQI Saab. Thank you so much, sir.
Bismillah ar-Rahman ar-Rahim. Thank you very much for the kind introduction. By the way, how many here are the house officers? Raise your hands. And TMOs? Well, because this is important, I'll skip some slides, I'll be more focused on that. So I'm thankful to the scientific committee for giving me this talk, the latest advances in hepatitis B management, what you need to know. And the learning objectives given to me are, I'll make them bigger on the screen. Understand the latest advancements in the diagnosis and monitoring of hepatitis B infection. The second learning objective given to me by the scientific committee is the explore current treatment options and emerging therapies of hepatitis B management. And the last one, the third one, apply updated guidance to optimize care and improve outcomes for patients with hepatitis B. So, take the first learning objectives. We all know hepatitis B is a major global health problem. This is 2019 WHO report, and it shows that worldwide prevalence of hepatitis B is 3.8%. And every year, 1.5 million new cases, they are reported or they enter into the pool of hepatitis B. And the mortality is that 0.8 million deaths due to HBV-related liver failure, cancer, cirrhosis, they happen. So the pool in the world is 296 million cases, and the bad point is 88% of this pool, it resides in Africa, Southeast Asia, and Western Pacific. And the dilemma is, according to 2019 report, only 10% of these 296 million were diagnosed and merely 2% treated. So this is the situation, and the countries most affected by hepatitis B, Pakistan resides here in the low intermediate. On average, the general population prevalence is 2.5%, but there are areas where it is touching 10%, even more than that. So this is the WHO 2030 goal to the whole world, elimination of hepatitis B. We heard a very excellent talk on the prevention. So the WHO says that by 2030, there should be 65% reduction in the mortality because of the hepatitis B and C, and 90% reduction in the new cases. We are in 2025 touching on that, and believe me, we Pakistani lag behind. We Pakistani are number one in terms of the hepatitis C infections, and among the top 3 in terms of the hepatitis B in the world. So you can just imagine how important this is for us. So just a few basics regarding the hepatitis B virion. We know hepatitis B virion for my younger colleagues, the HBV DNA, then the DNA polymerase, the E antigen, the core antigen, and the surface antigen. And this is important because the current HBV markers, what we do in the clinical practice, these are the S antigen and antibody to hepatitis B, S, E antigen, antibodies, then antibodies to core, and DNA PCR. This is the current markers we are doing in our clinical practice. So that the learning objective, that what are the novel markers? Yes, there are three most important novel markers which will be probably in the clinical practice very soon. One is the quantification of HBV RNA. Hepatitis B is a DNA virus, but it goes through the process of the RNA. So a quantification of HBV RNA, HB core related antigen. Clinically, we are not checking it, but now the assays are there, and quantification of anti-HBC antibodies. These are the novel markers which will be available to us. And what's their clinical significance? In the diagnosis. To diagnose HBV infection, particularly in patients with unclear or negative HBV serological markers, it can be used for that. Then in the monitoring, these parameters are important to monitor the effectiveness of antiviral therapy in patients with chronic HBV infection. And in the prognosis, again, they have got a role. High levels are associated with a higher risk of damage to the liver and HCC. So these will be used in the clinical practice for these three purposes. Just, we know that once hepatitis B, lifelong hepatitis B, just like diabetes, just like hypertension. But we see that acute hepatitis B, when it recovers within 6 months, actually this is the functional cure, where we lose the DNA, the patient loses the HBs antigen, but CCC DNA is still there. So this is just a functional cure. Most of the times, it follows the chronic phase, and with the treatment, what we get, it's a partial cure where the PCR becomes negative, but the HBs antigen still is positive, and this is called a partial cure. And believe me, at times it may go there, and at times the person with functional cure who was so-called recovered from acute hepatitis B can reactivate. This is very important when we will be discussing when to treat and when to stop the treatment. Ideally, when a patient loses S antigen, DNA, and the cccDNA, this is called a complete cure, and which is not possible with the current available treatment. That's the reason when we start these patients on treatment, most of the time this is a lifelong treatment. And we know this. This is the chronic hepatitis phase when the liver gets damaged in terms of the normal liver, fibrotic liver, and then cirrhotic liver. So this brings me to when to start antiviral treatment. Hamid Saab used to say, this is the most difficult question, when to start treatment, and another was when to stop treatment. So, and this we used to discuss this for decades, that this becomes very difficult. To start antiviral treatment, you have got two scenarios. First scenario is when you want to prevent reactivation. Patient is a functional cure, you want that it shouldn't, the HBs antigen shouldn't come. So this is the first indication to prevent reactivation of the hepatitis B virus infection. And the second is the liver, when the patient liver has got damaged and you want to control the hepatitis B virus infection. So by and large, these are the two scenarios when you offer treatment. We'll discuss this later on when we discuss the guidelines. When to stop? Depending upon the two scenarios, if it was started to prevent reactivation of hepatitis B virus infection, it's lifelong or till the risk of reactivation exists. But if you started the treatment because of to control the HBV infection, it depends upon type of the therapy and liver status, whether your patient liver is cirrhotic, fibrotic, or normal liver. How? Coming to the second option, that we started the patient on treatment because of the, to control the infection. If this was pegylated interferon, it's a finite therapy of 48 weeks, and you stop treatment. But if it was the orals, it depends upon, of course, the hepatic status. If your patient liver was cirrhotic when you started the treatment, it's a lifelong treatment. just like diabetes, hypertension. If the patient liver is fibrotic, again, it's a lifelong treatment. Don't think about stopping. You stop, it will recur, and even it come with more aggressive nature. It's only when the liver is normal, you can think about, yes, I can stop. And it again depends upon the E antigen positive and E antigen negative status. In E antigen positive, those patients who achieve the stable HB antigen seroconversion and untreatable DNA and complete more than 12 months of consolidation therapy, you can think about that, yes, I can stop. And practically, these are very negligible number of patients. For E antigen negative patients with normal liver who achieve long-term for more than 3 years, but close monitoring is very important, and most of these patients, they recur. So this is the situation of the current status. Coming to the second objective, explore current treatment options, which the scientific committee has given to me, and emerging therapies. Regarding the antiviral treatment, when the one drug is approved by the regulatory authority, and it takes 1 to 2 years, and then there's the post-marketing surveillance as well. For one drug, on average, 5 compounds underwent clinical trials, phase 1, phase 2, phase 3, and it takes 6 to 7 years. And to get these 5, more than 250 compounds in preclinical trials, they are studied, and it takes 1 to 2 years. This is the one drug story. And these 250 compounds, they come from more than 5 to 10,000 compounds. And it takes 3 to 5 years. So on average, to get one new drug, you need at least 10 to 15 years research. And starting from this amount of compounds coming, only this one drug. That's the reason drugs don't get discovered in a day. So the current therapies in 1992, it was interferon, then lamivudine came, then came the Edifover 2002, then 2005 entecavir, 2006 telbivudine, then the tenofovir, and then in 2016 TEF. Practically now there's entecavir and tenofovir which we rely upon. What about those drugs in pipeline? Yes, there are so many drugs in pipeline: replication inhibition, antigen reduction, immune stimulation, and those therapeutic vaccines, and exogenous HBS monoclonal antibodies. We won't go into the detail, time won't allow, but yes, there is hope that probably we will be able to get the cure for these patients. Coming to the last objective, apply updated guidelines to optimize care and improve outcomes for patients with hepatitis B. For this, to decide whom to start treatment, really you need to be among the wise people. आपको हमीद साहब और मसूद रहमान साहब जैसे और बाकी सब जैसे जो लोगों के करीब में होना, अंदर होना, दरमियान में होना चाहिए to see that yes, what are the guidelines. So to understand the clinical guidelines, you need tools of management. And these are the tools of management, so this is not as easy. You have to understand the FAM. Just remember, we discussed partial cure, then the functional cure, and then the complete cure. The partial cure is achieved with the current available drugs only. Plethora of guidelines have been there, but the last 2 guidelines, 2023, the Chinese, and 2024, the WHO, they really gave they shift the paradigm at 180 degree. How they? I'll just show you. The Chinese guideline says that when the HBS antigen is positive, you prevent reactivation, then you give the treatment, otherwise you do the DNA and all those things. The WHO, again, they give 4 options. We'll discuss this in comparison matter later on. But the old versus new, we are discussing where the indication was to control the infection. In cirrhotic liver, previous guideline said PCR needs to be detected. But the current guideline says no PCR is required. Just start these patients on treatment. In the fibrotic liver, previous guideline says viral load should be more than 2,000, L2 should be raised. The Chinese says just PCR positive is enough, and the WHO says PCR is not required. Coming to the normal liver, the previous guidelines, they depended upon whether this is the immune tolerant phase, reactive phase, escape phase, and only we used to be discussed. This was a question, when to start treatment, very difficult question. But now the Chinese guideline says PCR positive, AT raised, treat, PCR negative, don't treat. But the WHO, they says PCR more than 2,000, AT more than normal, treat, otherwise. So now the things are more inclusive. Yes, previously we used to say, start the treatment if it is indicated. Now it is start the treatment until it is contraindicated. So this is the change of the paradigm shift. Treatment protocol, very excellent given in these guidelines. We don't go into the detail, but you need to assess the severity of liver disease, LT-DNA levels, medical history, and family history. And then, of course, the counseling on the lifestyle, preparation for starting antiviral treatment, and preventive measures. And patient-centered approach must be adopted in treating these patients. These two are the drugs, tenofovir or entecavir. And of course, you monitor these patients. So I said, you need to be among the wise people to say how to use these clinical guidelines. And this was told to me that the guidelines are the tools of management. But the more wise girl by data, what she's saying, correct guidelines, these are the tools, not the rules. So you can go in between, you can use them. How? I'll share with you. If your patient is H-based antigen positive, look for these 3 current or co-infections. And depending upon these 2 guidelines, look for these 6 scenarios. If any one of these 6 scenarios is there, you treat this patient without doing PCR. But if these 6 scenarios are not there, then you go for the PCR. And I'm personally not in favor of the figures, the values, how many lakhs, thousands. To me, the Chinese guideline says just the qualitative PCR is enough. WHO says no, go for the 20,000. So irrespective of the figure, if the PCR is positive, and this is one important point, very old study, revealed trial. And they said even this was the number when more than 20,000, but what it says, even less than that, there's a risk of cirrhosis and HCC. So even a low viral load is not safe. And there's also, this is another old trial, detectable PCR, of course, when the level is high, it's high risk, but even at the low risk, there is chance of cirrhosis and HCC. So if the PCR is positive, treat this patient. But if the PCR is negative, then go for the LT levels. LT levels raised, WHO new figures are 30 and 19, 19 for female, 30 for male. If the LT is raised, start the patient on treatment. If the LT is normal, then go for 2. If your patient PCR is negative, LT is normal, age is more than 30, if the patient has co-infection, hepatitis C or D, you treat this patient, and this comes from these guidelines. I can't go into the detail of this, but this comes from these guidelines. This is based on these guidelines. So don't treat and do these 6 monthly follow-up. So you can mix both these two, and I call this always a GIFS hybrid treatment algorithm. Both these options, all these options are within those 2 guidelines. So instead of following one or another, you can mix them for the better control of these patients. So I think this gives me the opportunity to have a good treat, because what I have done, that I have mixed all those, and you can simplify your algorithm, you can simplify your treatment options, because if my patient with low viral load is going to develop HCC or cirrhosis, definitely I won't want that my patient should go into that state. So thank you very much once again for the kind the invitation to this, and I hope that with these new guidelines, we will be able to achieve or at least go nearby the hepatitis elimination given to us by the WHO. You can just, these slides will be available on my YouTube channel, so you can go and you can download these. Thank you very much.